And when we talk about syndesmosis injuries isolated in athletes, there's still a lot of controversy, but gradually more and more consensus. And thanks to the research from all our groups together all over the world, we are now gradually getting out of the hole of no knowledge and knowing now how to test for instability, how to choose the right treatment, and especially what we can explain our athletes on the return to play, the guidelines and the expectations once they suffer from an injury that is an isolated syndesmosis injury. And the visual picture always prevails. This is how it works. Now, this is an athlete that is sent to us with an ankle sprain. You and I will agree that this is not an ankle sprain, and it's not even a high ankle sprain. This is not an inversion plantar flexion injury. It is a dorsiflexion external rotation injury. So we have to speak the same language. And when we talk about ankle sprains, this is the most essential part, that we say there is no such thing as a simple ankle sprain. And our journey here with the team of foot and ankle at Aspetar started about 6 years ago, where we had the chance to evaluate an MRI on all the acute lateral ankle sprains that were sent to us. And strikingly, although the mechanism of injury is so different, the pathology is so different, still 20% of athletes referred for a lateral ankle sprain showed suffering problems and evidence of syndesmotic injury over that ankle. So it is not the same mechanism, it is not the same pathology type, but it is altogether in the whole spectrum of lateral ankle sprains incorporated. And we wanted to know more about that. So what do? We dig into the literature. But strangely enough, except from some cohort studies and athletic studies around collegiate athletes in the States, there was nothing out there. So we had the chance to team up with the UEFA database on elite football led by Professor Ekstrand. And what we did is follow the athletes, over 3,600 athletes, over 15 consecutive seasons of professional European football. And we documented the injury incidence and the injury burden. And what did we see? We saw that the injury incidence during match play is 14 times higher compared to the training ground. There's a 7.5 annual increase in injury incidence. Just for your knowledge, in a few recent publications in the past, it was mentioned that it was less than 0.4%. And actually, this shows that this is a problem that is much more predominant than we think. We are now hosting the Asian East Champions League 22 teams competition here. And this early morning, we even had to perform a surgery on a similar injury. It is out there and it is increasing. Knowing also that 74% of the injuries are contact related and the mean is more than 5 weeks of a layoff, meaning much more than a simple so-called ankle sprain. What do? We wrap up the way of dealing with this athlete coming in. We listen to the mechanism of injury, we look at it if we can, and we see if there is radiation up. We look especially on the imaging, we do the testing, and we feel. We use the tests that are out there, although they are provocative, they are not pathognomonic at all, but they are helpful in the full assessment in the menu of options that we can use in order to identify stability versus instability. I told you that most of the injuries in our data are contact related and match play related. Well, this is a training ground of a Premier League team, a player that was sent to us a few weeks ago with the video. This is not an ankle sprain. This is a player that gets stuck without any contact in a simple training ground movement that he performs or she every day. And look, still you have that dorsiflexion, getting stuck into the ground, external rotation injury. This has nothing to do with an ankle sprain. And now a little teaser for you all. When I say it's not an ankle sprain at all, we believe that with the similarities of the ACL pathology that we see, that is that there's no such thing as an ankle sprain, but also we should get rid of the title high ankle sprain because it has nothing to do with an ankle sprain. It is a syndesmosis pivot. And of course, we need to validate this idea, but we are pretty convinced that it's the position on the foot on the surface, as Dr. Athol Thompson clearly identified in his research and in the session of today, that there is a link between the foot position, the surface, and the eventuality of a syndesmosis tear versus an ACL tear. Our teams now are working on that, more to come, but just to send you a message that we might in the future think more about a pivot than a really high ankle sprain nomenclature, because there is so many striking similarities with that mechanism that I've just explained. So back to the syndesmosis injuries, we have a classification that we can use. Grade 1 is never requiring surgery, grade 3 predominantly most of all, but in general most of these injuries present as grade 2s. And when we go back to the literature, we just want to know, is it stable or not? Is it stable? You don't need surgery. Is it unstable? There might be a somnolent or subtle instability that has to be tackled from the start to avoid that annoying chronicity of syndesmotic injuries that are very much more hard to treat. When we are saying that there are signs of instability, we majorly mean that there would be a deltoid ligament injury and or a positive squeeze test or external rotation test and or a widening on the X-ray with a radiation up to the IOL area plus 5 centimeters. It's a bit technical, but it is the challenge in syndesmotic isolated injuries, because if it's unstable and we didn't identify it, we will regret it 2-3 months down the line. So what do? We look at the golden standard. What is the golden standard? That is arthroscopy. But that means that many of our players will receive a sort of diagnostic arthroscopy saying that it's not unstable and they actually didn't need surgery. So that's not the way we want to work. That's not the philosophy that we cherish. So we came up together with Slim Boudida and many of our team with a device that we validated. What did we do? We went to the cadaver lab and looked how a syndesmosis opened in the ankle, and we validated that blindly with a physiotherapeutical assessment with the device. And we saw that in a particular dorsiflexion 20 degrees, there is 100% significant similarity, which means that only in that position we can rely on the device to say through a non-invasive approach, yes, as part of the options, this is a stable versus an unstable injury. I will not run into the imaging specificities. You all are aware of that, and it's all out there. Now, we also know that it's easy to say in a hospital focusing on athlete problems, we do MRIs and we see what's going on. But here we are, all team physicians in a stadium, in a room where there's only, for example, an ultrasound available. Well, our data showed now that an ultrasound has good to excellent diagnostic value for complete discontinuity identification of the lateral ligament, ATFL, and the AITFL. So here we are. You don't even need your fancy material in the initial assessment. You can stick with your ultrasound and master that. That's new, that's helpful, and that's a good message to all of us. Of course, there are MRIs, CT scans, and diagnostic arthroscopies. We all know that, and we can read about it in a more specific way. This is how it looks like. On the lateral side, left, you see the AITFL synovitis and the IOL diving into the joint, creating that very annoying anterolateral impingement of the syndesmosis. On the right side, you see a deltoid injury that is always a much more debatable injury to treat, but when you perform a combined arthroscopy, you can identify it, treat it, and at least cover the expectations of the athlete in the most detailed way. How does that look like? On the right side, you see a hook test. If you're not sure, you just go into the syndesmosis between the fibula and the tibial plafond, and you see if you can open it up over 4.5 millimeter, which is the hook length that you can see right now. You can also do it through a sort of shaver device where it's around 4 to 5 millimeter deep, and in a gently manner, if you can introduce it, it means it's unstable. So easy, right? Well, I can tell you, when you look at the literature and they say golden standard is arthroscopy, in these grade 2B injuries that are subtle instabilities, it doesn't look like that. And then you go to the nomenclature and you say, okay, what is the validated outcome to do that? Well, there's none. So we came up with an idea to put a dynamometer on that shaver and gradually cut the ligaments, AITFL, IOL, PITFL, and then deltoid. And by doing so, we try to bridge the gap between the tools that we have for the moment and the instability itself, and to see whether industry can in the future help us to talk the same language in the world and to at least create data that we can use for our research to proceed, to progress, and to, as I said, improve in our treatment strategies. So this is the data that is on that paper. And furthermore, we have talked about the mechanism, about the diagnostic setup, and about the imaging. But how do we treat them? And we all know there are screws and suture buttons out there. They all have their pros and cons. I will not go into detail. The pros of the screws in general are that the fixation is really rigid. The pros of the suture buttons is more that it allows for athletic participation a bit faster, a bit more forgiving into rigidity, and you don't have to remove them. More than happy to discuss furthermore in the links that we have provided with you. The real question is not how to treat them. The real question is there is still a big amount of malreduction out there, wherein about half of the cases, if you look at CT scan postoperatively, especially in fractured cases, that you have a malreduction compared to the contralateral side. This is unacceptable. And why is it acceptable for the moment? Because the ankle congruency is very forgiving for the initial stage, but not at a later stage with osteoarthritis as the final victim. So we now know how to put them in position. We know how to treat it. We know we have to compare with our imaging the contralateral side, and that's the way forward. The real other question in malreduction that is much of the problem is what is normal. If you look at the variability of the distal ankle, you will see that it's very hard to compare normal versus abnormal because it's all different sizes of anatomical landmarks. And that's still the real question and the real problem that we are facing and the challenges that we have to overcome. So Dr. Alberto already instigated the idea of the research at the benefit of the clinical applications. Well, we're very humbled with the award that we won from the American Journal of Sports Medicine with our systematic review on the value of these suture buttons versus screw fixations in our athletes. So it is out there. There's much more of it than we realize. And nowadays, we try to create more consensus than controversy. And more nice papers are coming up. And one of them is, for example, from the Pittsburgh group, where they say hybrid fixation is the future, where they use suture buttons together with plate and screws. Another Irish group does beautiful work on the tackling itself. And it's not just about treating the problem, it's also bringing it to the table of the leadership and the regulatory bodies, meaning that in most of these cases, we see that it occurs due to a bad tackle, which means if we can convince our referees and our governing bodies in sports that this is unacceptable, then more and more of these injuries can be prevented, and hopefully it will be going down instead of increasingly up annually. One of our papers on that is that it's not an or screw or suture button, it's an and. We use a screw in a fracture case for fixation rigidly, and then we remove it and alter it or replace it by a suture button for early mobilization. Use the wins of both and remove the disadvantages of both. So how can we improve? We've done an international survey on 970 sports medicine foot and ankle surgeons all over the world. And interestingly, there is a fantastic geographical difference in how we diagnose and how we treat. So although we try to speak the same language, although we have so much data already out there, many of us in different continents still treat it in a very different way. That is something that we will present at the next ISACOS Cape Town meeting, because it's a paper that is prepared from our group there, and very much excited to elaborate more on that in the near future. A very last word on the return to play, because that's the real message to your athlete who comes in with the question of, what am I going to do now with my unstable syndesmosis? Well, we have looked into our data over the last 5 years, and we've identified 110 male professional football players with an isolated syndesmotic unstable injury that required surgery. And this is a very homogeneous group in the type of sport level that we were aiming for. What did we see? We saw that there's a return to play on competition, a return to play on rehabilitation, and a return to play on the team. And the results that we have is, for the first time, because there's nothing in literature strikingly before, is that we can tell our player, if you have had surgery, your return to on-field rehabilitation will be around 37 days. Your return to train with the team will be around 72 days. And your return to first match will be around 103 days. And with that, I would like to end the presentation and